Hi, everyone. Welcome back to my podcast, Anatomy and Physiology Bit by Bit. I'm your host, Dr. Steve Sullivan, coming to you from Bucks County, Pennsylvania, where I've been teaching A&P since 2002. In this episode, we're going to finish up the urinary system, but first I want to answer a question I got from a listener recently. Just last week, Sarah from the United Kingdom wrote to me to tell me how much the podcast has helped her in her studies to become a nurse, and she wrote a really nice and complimentary email. I want to thank Sarah for that. It makes my day when I see that people are benefiting from the podcast. I really love that. Anyway, she asked, what causes kidney stones? Since we're in the urinary system, that's a pretty good topic. So let's start with what kidney stones are. Kidney stones are hard mineral and salt deposits that form in the kidneys. They develop when urine becomes too concentrated, allowing minerals and substances to crystallize and stick together. Those stones, which we also call nephroliths, advance to the ureter because of the pressure of urine trying to leave the kidney. The ureters are narrow and muscular, and they have a lot of nociceptors, so the stones in the ureter can be extremely painful. Several factors contribute to the formation of kidney stones, including dehydration, diet, medical conditions, and genetic predisposition. So let's talk about those individually. We'll start with dehydration. One of the primary causes of kidney stones is not drinking enough water. When the body's dehydrated, the urine becomes more concentrated, meaning it has less fluid to dissolve the minerals and salts. The high concentration increases the likelihood of crystal formation, and people who sweat excessively, such as athletes or people who live in really warm climates, are at higher risk because they lose fluids and salts through the sweat. There's also dietary factors. Certain foods and dietary habits can increase the risk of kidney stone formation. One example is high oxalate foods. An oxalate is a naturally occurring compound found in many foods and also produced by the body as a waste product. Chemically, oxalate is an organic acid that binds with minerals, especially calcium. That binding takes place in the digestive system and the kidneys to form calcium oxalate stones, which is the most common type of kidney stone. Foods that are high in oxalates include spinach, beets, nuts, chocolate, tea, and sweet potatoes. These are just some examples. Another dietary factor is excessive sodium intake. High sodium in the diet can increase calcium in urine, raising the risk of stone formation. Salty foods, processed foods, and fast food are major sources of excessive sodium. High animal protein diet, consuming too much red meat, eggs, and seafood can lead to two different risk factors: increased uric acid levels, which contribute to uric acid stones, and reduced citrate levels, a natural stone inhibitor in urine. Also, if you're not getting enough calcium in your diet. Even though calcium is involved in stone formation, not getting enough calcium can actually increase the risk, because when calcium is low in the diet, more oxalates are absorbed into the bloodstream, leading to stone formation. There's also some medical conditions that make people predisposed to kidney stones, like hyperparathyroidism. Overactive parathyroid glands increase calcium in the bloodstream, and that can increase the kidney stone risk. Urinary tract infections. Some bacterial infections create struvite stones, which grow quickly and can become really large. Gout. High uric acid levels, which is common in gout, can lead to the formation of uric acid stones. Obesity, diabetes, and genetic factors can also increase your predisposition to forming kidney stones. Now, there's also some medications and supplements that might increase your risk of kidney stones, like certain drugs, like diuretics and acids that contain calcium. Certain antibiotics may promote kidney stone formation. Also, if you take excessive amounts of vitamin C and calcium supplements, you could increase your risk. An imbalance in urine pH can also change your predisposition to kidney stones. Acidic urine promotes uric acid stones, and alkaline urine promotes calcium phosphate and struvite stones. All right, so quick review. Kidney stones form due to a combination of dehydration, diet, medical conditions, genetics, medications, and urine pH imbalances. Drinking enough water, maintaining a balanced diet, and managing underlying health conditions can help reduce the risk of kidney stones. So what do we do about kidney stones if you have them? If you have small stones with minimal symptoms, you can treat it by drinking more water, taking pain relievers to decrease the discomfort, ibuprofen, which is Advil, Aleve, which is naproxen sodium. And then there's also medical therapy. Your doctor could give you a medication to help pass your kidney stone. This type of medication, known as an alpha blocker, relaxes the muscles in your ureter, helping you pass the kidney stones more quickly and with less pain. Kidney stones that are too large to pass on their own or cause bleeding, kidney damage, or ongoing urinary tract infections may require more extensive treatment. They might use ultrasound waves to break up the stones. We call that lithotripsy. Surgery. They could actually go in with a surgical procedure, a nephrolithotomy, to remove the stone surgically. They could use a scope to remove a smaller stone in your ureter or kidney. Your doctor could pass a thin lighted tube equipped with a camera through your urethra and bladder to your ureter. Once the stone is located, special tools can either grab the stone and pull it out or break it up into pieces so it's easier to pass in your urine. And then finally, if the parathyroid glands are the culprit, which are located on the four corners of your thyroid gland in the posterior, when these glands produce too much parathyroid hormone, your calcium levels can become too high, like we said earlier, and the kidney stones could form. Hyperparathyroidism sometimes occurs when a small benign tumor forms in one of your parathyroid glands, or you develop another condition that leads to these glands to produce more parathyroid hormone. Removing the growth from the gland stops the formation of kidney stones, or your doctor may recommend a treatment of the condition that's causing your parathyroid gland to overproduce the hormone. All right, so I hope that answers your question, Sarah, about kidney stones. These are really common clinically, and if you're going into a clinical profession, you're going to see kidney stones at work. It's really good to ask questions about clinical stuff that I can answer on the podcast, and I really hope that this helps you understand that particular condition better. All right, so let's get back into finishing the content of the urinary system. In the last episode, we finished up with tubular secretion and the remaining reabsorption of water. So let's pick up with water conservation and urine composition. So just a quick note, I want to mention that there's a lot of anatomy talk in this episode, so I'm going to post some images to my Instagram account, Student Help for AP, so that you can follow along with some illustrations of the anatomy that I'm discussing. So check that Instagram account out, follow me if you can, and you'll be able to follow along with some of those illustrations. Now, not only do the kidneys eliminate metabolic waste from the body, remember they also prevent excessive water loss, supporting the body's fluid balance. As they return water to the blood plasma, the fluid remaining in the renal tubule becomes more and more concentrated in the collecting duct. So let's examine the kidney's mechanisms for conserving water and concentrating the tubular fluid before eventually becoming urine. So the collecting duct begins in the cortex, where it receives tubular fluid from multiple nephrons. As it passes through the medulla, it usually reabsorbs water from the tubular fluid and into the tissue fluid of the renal medulla. This process concentrates the urine, meaning the solute concentration increases. When the tubular fluid enters the upper end of the collecting duct, it is isotonic with blood plasma, each at about 300 milliosmoles per liter. By the time it leaves the collecting duct, so much water has been reabsorbed, the tubular fluid can be up to 4 times as concentrated as blood plasma. The tonicity of urine is high for 2 reasons. First, the tissue fluid in the lower part of the renal medulla is 4 times more concentrated than the tissue fluid of the renal cortex. This means the osmotic gradient greatly favors the movement of water out of the collecting duct. Second, the cells of the collecting duct are more permeable to water than they are to solutes, so the water gets reabsorbed, exiting the collecting duct, while solutes remain, making for a more highly concentrated urine. The rate at which the kidneys produce urine and how concentrated it is depends on how hydrated you are. If you've been drinking a lot of water, staying very hydrated, the upper region of the collecting duct reabsorbs more sodium chloride, but is impermeable to water, so the water stays in the urine, while the solutes do not. This results in urine with a low osmolarity, which is typically clearer in color. When hydration is low, the kidneys produce less urine, and it is darker because it is more concentrated, meaning a higher osmolarity. As we've discussed before, dehydration increases the osmolarity of blood plasma, which stimulates the hypothalamus, which then stimulates the posterior pituitary gland to release antidiuretic hormone, or ADH. ADH reduces urine production by immediately increasing the number of aquaporins in the wall of the collecting duct, which results in an increased water reabsorption. Now, those aquaporins were on standby in the cytoplasm. If ADH remains elevated for more than a day, it stimulates the cells of the collecting duct to begin synthesizing even more aquaporins to further increase water reabsorption and decrease urine output. Each collecting duct heads toward the papilla of the medullary pyramid, where they merge to form the papillary duct. About 30 papillary ducts reach each papilla, where urine is drained into a minor calyx. At this point, urine has some distinct properties. We'll start with the chemical composition. On average, urine is about 95% water and about 5% solutes. By volume, urea, sodium chloride, and potassium chloride are the most abundant solutes in urine. We also see some creatinine, uric acid, phosphates, and sulfates. And finally, there may be some traces of calcium, magnesium, and bicarbonate. Urine typically has a mildly acidic pH of about 6.0 due to the excretion of metabolic acids. Depending on hydration level, the osmolarity of urine can range anywhere from 50 milliosmoles per liter to 1200 milliosmoles per liter. The more hydrated you are, the lower the osmolarity will be. And believe it or not, urine shouldn't have a very strong odor when it leaves the body. But if it sits too long, bacteria will break the urea down into ammonia, which has a distinctive and pungent smell. You may have noticed that asparagus can give urine a distinct smell. This is because of the asparagine acid of asparagus, which is broken down into sulfur compounds that make their way into the urine. Now, the interesting thing is that not everyone notices this odor because some people lack the olfactory receptors to detect it. The color of urine depends on your level of hydration. If you're well hydrated, urine is likely clear or close to it. The more concentrated the urine is, the darker it is. So if you're less hydrated and your body is conserving water, urine will be more concentrated and lower in volume. The color of urine can sometimes take on unexpected shades. While some do, not all color changes indicate a serious health problem. For example, urine that appears red or pink is often alarming but isn't always cause for concern. Blood in the urine, known as hematuria, can result from various health issues like an enlarged prostate, kidney stones, cysts, or even tumors. But it can also be triggered by strenuous exercise. Certain foods like beets, blackberries, and rhubarb can tint the urine red or pink. And some medications may also play a role. Vitamins A and B12 can cause urine to take on an orange or yellow-orange tone. However, in some cases, orange urine may be a sign of a more serious issue such as liver or bile duct problems. Dark brown or cola-colored urine may be a result of dietary choices, medications, or more serious health conditions like internal bleeding or a rare group of disorders known as porphyria may be responsible. Extreme exercise can sometimes lead to muscle injury, which releases pigments into the urine, causing it to take on a tea or cola-like color, an indication of potential kidney damage. Cloudy or murky urine is often linked to bacterial infections or kidney stones. So that's a really good look at the composition of urine and what different colors of urine might mean. I want to get into how we concentrate those fluids and make sure our concentration gradients are what they should be. So, as we've seen, the osmotic gradient in the kidneys is paramount to their function. So, let's think about how we maintain that. The osmotic gradient between the collecting duct and the tissue fluid of the lower renal medulla has to be maintained so the collecting duct can concentrate the urine. If the salt being reabsorbed diffuses from the renal medulla to the renal cortex, it'll be difficult for water to leave the collecting duct via osmosis. This is avoided by the nephron loop of largely juxtamedullary nephrons acting as what is referred to as a countercurrent multiplier. Countercurrent means the tubular fluid in the descending and ascending limbs of the nephron loop are traveling in opposite directions. Multiplier because the osmolarity of the tissue fluid in the region is multiplied. So let's talk about how this works. First, take note that the descending limb of the nephron loop is more permeable to water than it is to salt. Also recall that a lot of salt is being reabsorbed into the tissue fluid by the proximal convoluted tubule, which creates an osmotic gradient that favors the movement of water from the tubular fluid of the descending limb into the tissue fluid. So now the tubular fluid heading toward the bottom of the loop is getting more and more concentrated. Compare the osmolarity of the end of the PCT, the proximal convoluted tubule, which is 300 milliosmoles per liter, to that of the bottom of the nephron loop, which is 1200 milliosmoles per liter. That's 4 times saltier. The thick segment of the ascending limb is mostly impermeable to water, but it is permeable to salt. So it pumps a lot of the salt back into the tissue fluid, decreasing the tubular fluid's osmolarity as it approaches the distal convoluted tubule. Once it is in the distal convoluted tubule, the osmolarity drops to as low as 100 milliosmoles per liter. Due to its reabsorption by the collecting duct, urea contributes to a large portion of the tissue fluid's osmolarity in the renal medulla. However, it diffuses back into the thin segments of the nephron loop, and it's always being added to the filtrate by the glomerulus, so the urea content of the collecting duct remains high, even though it's being reabsorbed. The large volume of water reabsorbed by the collecting duct cannot stay in the renal tissue fluid. It has to return to the blood plasma, and it does that via the capillaries of the vasa recta. However, the salt and urea concentration of the tissue fluid has to remain high. The vasa recta can't reabsorb at all, so they form what's called a countercurrent exchange system. The capillaries of the vasa recta do not bend and twist around the nephron loop like the peritubular capillaries do around the convoluted tubules. Rather, they're arranged in more of a long, parallel fashion along the length of the nephron loop. The capillaries that are parallel to each other have blood traveling through them in opposite directions. This is why we see the term countercurrent again. This time we're exchanging water for salt. As the blood flows deeper into the renal medulla, water is filtered out of the capillary and salt is absorbed into it. As the blood returns back up toward the renal cortex, the salt is returned to the tissue fluid and much more water is absorbed into the capillary than was filtered out. So the net result is water being reabsorbed into the blood plasma, while the tissue fluid's salt concentration and, in turn, osmolarity is maintained. Once the kidneys produce urine, it must be stored and eliminated from the body. So now let's talk about the structures that do this and how they do it. The urinary tract is the path urine takes to leave the body. It includes the kidneys, the ureters, the urinary bladder, and the urethra. We've covered the kidneys extensively, so let's now consider the structure and function of the rest of the urinary tract. From each kidney, urine drains from the renal pelvis into the ureter. The ureter is a tube with multiple layers of smooth muscle that leads to the urinary bladder. From the minor calyces on down to the proximal urethra, the internal surface of the urinary tract is lined with transitional epithelium. Transitional epithelium is unique to the urinary system and is sometimes referred to as urothelium. You may remember from previous episodes about tissues and histology, I talked about transitional epithelium. The surface epithelial cells of urothelium are thicker than usual and have protective proteins called uroplakins. Uroplakins protect the underlying tissues of the urinary tract from the acidity of the urine. When the urinary bladder is empty, the uroplakins are folded into the cells for storage, making the cells seem more cuboidal in shape. When the urinary bladder is full, the uroplakins are spread out over the surface of the cell, making them flatter and more squamous-like in appearance.
You buy a pair of socks, that's 2 socks. You buy a pair of Bombas socks, that's 4 socks. Because one purchased is one donated. Socks are the #1 most requested clothing item in homeless shelters. So when you buy a pair of super comfortable Bombas socks, you're also donating a pair. Bombas customers have powered over 150 million donations. So Bombas would like to thank you 150 million times. But we only have like 30 seconds. Go to bombas.com and use code AUDIO for 20% off your first purchase. That's BOMBAS.com and use code AUDIO at checkout.
The urinary bladder is a sac whose wall consists of 3 layers of smooth muscle, collectively known as the detrusor. The urinary bladder is in the pelvic cavity, inferior to the peritoneum. The internal surface is wrinkled when empty, and those wrinkles are called rugae. When the bladder fills, the wall stretches and the rugae flatten out. The urinary bladder can hold up to 800 milliliters of urine at maximum capacity. So the urine drains out of the ureters and into the urinary bladder at the bilateral urethral openings, which are located at the posterior and inferior aspect of the urinary bladder. The urine is drained from the urinary bladder into the urethra, which then takes urine out of the body. We can draw a triangle using the 2 urethral openings and the beginning of the urethra, and that triangle is known as the trigone, and it has no rugae. The urethra are not the same in biological males as they are in biological females. But let's consider the urethra is not the same in biological males as it is in biological females. But let's consider what they have in common first. The urethra begins at the base of the urinary bladder, where it is surrounded by a circular band of involuntary muscle. That muscle is called the internal urethral sphincter. Moving distally, there is a circular band of voluntary muscle called the external urethral sphincter. The distal opening where the urine exits is called the external urethral orifice. In biological females, the urethra is shorter than in biological males. It's only about 3 to 4 centimeters long, and the external urethral orifice is just anterior to the vaginal opening. The urethra in biological males is utilized by the urinary system and the reproductive system. The urethra of the biological male is divided into 3 segments. The prostatic urethra is the most proximal segment. It passes through the prostate, which is an accessory gland of the reproductive system. The second segment is the membranous urethra, which has the external urethral sphincter wrapped around it. And the third is called the spongy or penile urethra because it passes through the corpus spongiosum of the penis. The mucosa of the penile urethra consists of pseudostratified columnar epithelium, and the distal tip consists of stratified squamous epithelium. Every few seconds to few minutes, depending on how frequently urine enters the ureter from the renal pelvis, the urethral smooth muscle contracts, squeezing urine toward the urinary bladder. The urine begins to fill the urinary bladder as it makes its way in through the urethral openings. Eventually, we have to empty the bladder, and we call that urination or micturition. And it has an involuntary and voluntary component. This way, the process begins, but we can decide when to let the urine go. The involuntary component is called the micturition reflex, and we'll start there. As urine fills the bladder, stretch receptors in its wall are stimulated. The result is sensory nerve signals that travel along the afferent fibers of the pelvic nerve to the S2 and S3 levels of the spinal cord. Parasympathetic preganglionic fibers from S2 and S3 conduct efferent nerve signals to parasympathetic ganglia near the detrusor muscle and internal urethral sphincter. These efferent signals excite the detrusor, so it contracts and squeezes the urine in the bladder, and inhibits the internal urethral sphincter, so it relaxes, allowing the urine to exit the urinary bladder. But we still have the external urethral sphincter closing it off because that is voluntary. When the detrusor contracts, epithelial valves at the urethral openings block the urine from backtracking into the ureters. At the same time, the micturition center of the pons receives signals from the bladder stretch receptors. If you're ready to go, the pons sends efferent signals via the spinal cord that contract the detrusor and relax the internal urethral sphincter. If you're not ready to go, nerve signals under conscious control from the cerebrum excite the external urethral sphincter, keeping it contracted so that the urethra is closed and urine can't exit through it. When you're ready to go, the cerebrum inhibits the external urethral sphincter, relaxing it and allowing urine to be voided from the bladder. All right, so that's it for the urinary system. I hope that this has helped you. I really appreciate you listening, and I really appreciate the questions coming in from listeners. Thank you, Sarah, from the United Kingdom, for sending in that question about kidney stones. And don't forget to check me out on Instagram, Student Help 4AP, the number 4AP, and YouTube, which is the same. I'm posting things on there. There's some videos on there that you can use to help you understand some of these complicated concepts. I really appreciate you listening. Once again, share this with your professors, share it with your colleagues, with your students, your fellow classmates, all that stuff. That would be great. I want to see what we can get to. We had a really exciting news last week where on Spotify we were rated the number 16 educational podcast on all of Spotify, and also an organization ranked us as the number 1 anatomy and physiology podcast that you can get. So that was really exciting. Thank you so much for doing that. Please share. And once again, I hope this is helping you get your B or better in A&P, and I'll talk to you next time. Anatomy and Physiology Bit by Bit is a production of Minus 55 Media. Don't forget to check out my Instagram account and my YouTube channel, both called Student Help for AP. I'm posting a lot of stuff on there right now that you can watch and that will hopefully really help you understand this A&P stuff. Very special thank you out to my family, Bucks County Community College, and McGraw-Hill Education, where you can find my tutor video-based textbook alternative Anatomy and Physiology digital suite, already being used by several colleges and universities throughout the United States.